Good afternoon, everyone. Welcome and thank you for joining us for our 5th session of the Public Health Alliance Regional Equity Learning Collaborative, today focused on embedding equitable data practices in local health jurisdictions and data systems. My name is Anna Bonilla. I use she, her, ella pronouns, and I'm the Health Equity and Justice Manager with the Public Health Alliance of Southern California. And I'm pleased to also share that I am joined by my co-facilitator colleagues today, Savannah North, Delia Melendres, and Colleen Bodenreiter, and I'll go ahead and let them introduce themselves.
Good afternoon, everyone. My name is Savannah North. I use she, her pronouns, and I'm the Director of Administration and Climate Initiatives. Lovely to have everyone today.
Hello, everyone. My name is Delia Melendres. Pronouns are she, hers, and I'm the Health Equity and Justice Coordinator.
Hi, everyone. My name is Colleen Bodenreiter. I use they, them pronouns, and I am a data analyst at Public Health Alliance.
Great. Thank you, everyone. So for today's collaborative session, we'll be holding space for conversations, cross-jurisdictional learning, and sharing around strategies to embed equity in local health jurisdiction data systems and processes, and take it further to hopefully begin exploring and having meaningful conversations around how to move to action locally and as a region. And as we're getting started, I also want to invite you to introduce yourselves in the chat. You can share your name, your pronouns, your role, and your local health jurisdiction that you're joining us from. And while we go ahead and get those introductions in the chat, I'd like to invite Tracy Delaney, Founding Executive Director of the Public Health Alliance of Southern California, to share a few welcoming remarks with us.
Great, thank you, Anna. Well, welcome and good afternoon, everyone. We're so pleased that you joined us today. It's almost been a year since we launched our Equity Learning Collaborative in response to the need to create space for cross-jurisdictional learning and sharing across the most salient and emerging equity issues, both locally and as a region. We've covered topics about how to build internal capacity, addressing racism as a public health crisis, authentic community engagement and co-creation, and most recently, equitable workforce development. Together, we've built a strong foundation for health and racial equity. And during today's session, we will use these foundational understandings to help guide us through more equitable data practices. Well, at the Public Health Alliance, data is in our DNA. We are the proud developers of the California Healthy Places Index, a powerful and easy to use data and policy platform created to advance health equity through open and accessible data. Through the HPI platform, we've been able to support efforts that prioritize equitable community investments and develop crucial programs and policies across the state. As most of you know, the HPI was used by the state of California to develop their COVID health equity metric, and then later the vaccine equity metric. To date, the HPI has been used to allocate more than $1.5 billion to communities that need it the most. I had the pleasure of talking with Tony Eiten from the California Endowment earlier this week, and he said he believes there should be no stories without data and no data without stories. Community voice and engagement is essential for data to be a positive tool for equity. That's why I'm so excited that my friend and colleague, Deborah Williams, is joining us today as a guest speaker to share her experiences. Thank you again for being with us today and for your enduring commitment to health and racial equity. Thanks, Anna.
Great. Thank you so much, Tracy, for your remarks and your welcoming statements. And again, also welcome to Deborah. So glad that you could be here and join us today as well. So as always, we have our housekeeping rules to help us run a smooth virtual learning environment and collaborative space. So we welcome you. If you're in a place where you're able to, I invite you to turn and keep your cameras on. As well, we wanted to highlight that today we're going to have several opportunities to engage with polls where we want to hear from you. So we'll be using the Slido platform where you can engage through your phone or through your computer to respond to some questions. And as a friendly reminder, we are recording today's session, and we plan to make the recordings of the presentations and the guest speaker available after today on our collaborative webpage. We also want to take a moment again to acknowledge, raise awareness, and hopefully spur action around our role as settlers in the US. We acknowledge the importance of land acknowledgements, and we want to move towards becoming better settlers. And what does it mean to go beyond a land acknowledgement? It means creating an action plan. A land acknowledgement without a call to action and next steps can seem performative. So what can you think about including in an action plan? You can look at resources and how you can share your time, money, land. You can do additional research on if there is a local voluntary land tax, land return movement, or if there are ways where you can show up and find out about what's happening locally in your own community. We've gone ahead and dropped some links in the chat with some resources that you can further explore on your own. Now, the last time we were together in July, our fourth session focused on strategies for equity and workforce development. We shared common definitions and language and introduced the concept of workforce development ecosystem and shared strategies and recommendations to implement and address equity across our workforce development practices. We were so pleased to be joined by Lori Williams, Director of Public Health in Stanislaus County, and Alejandro Juarez, Workforce Equity Manager with Multnomah County in Oregon. And we were really fortunate to hear about the work that they were doing locally and how they are planning to move that workforce equity work in their jurisdictions in the future. For today's session, we are excited to provide an overview of the fundamentals of equitable data practices and how they can be applied in your own local public health data systems. We'll provide some foundational principles, introduce some shared language, and review some best and promising practices for embedding equity in your data systems and your work. Following our overview and recommendations, our colleague Colleen with the data team at the Public Health Alliance will share more about the latest iteration of our Healthy Places Index and how the mapping data and policy platform can be an incredible tool to advance your equity goals and objectives. And again, I'm also pleased to share that we will be joined by Deborah Williams with Building Resilient Communities, who will share more about their incredible work during their COVID-19 response and potentially offer insights on how we can apply the lessons learned to the current Mpox outbreak. And as always, we will reserve time at the end of our session to meet together in our equity change teams in order to hold space to discuss in your local teams, both intentionally on how to strategize around how to apply these concepts more in your local health jurisdictions. So let's jump right in. So we wanted to address a little bit about why it's important to focus on equity and data. Public health data and data systems really help us take the pulse of our society. Data helps measure and track the indicators that we use to gauge the overall health and well-being of our communities. Public health data systems are essential to achieving health equity and racial justice, and they can be a powerful lever for change to inform policy actions and ultimately lead to policy and systems change. And it's not just limited to public health as a field. Public health data systems are also inclusive of other sectors such as the environment, criminal justice, human services, employment, just to name a few. Data are also the building blocks of the population health narratives in our communities. These are the stories that emerge from our collection and analysis of the data. And these help drive and contextualize what impacts our health. And what data are collected and how they are collected and interpreted help us ultimately shape these narratives. And lastly, data help us identify and understand the root and structural causes of inequities in health outcomes. So we wanted to hear from you because, one, you're already all using data in your work in some way and in some capacity. But secondly, we wanted to elevate the 10 essential public health services as defined by the CDC to really outline how it's so integral into how we perform our work or do our work in our community as public health. So as you can see from the graphic, you can see how data fits in very clearly through several different categories. You can see it through assessing and monitoring population health, investigating and diagnosing to address the health hazards and root causes, and also how we improve and innovate through evaluation, research, and quality improvement. But we also wanted to just really underscore that there are even more implicit and embedded ways that data can support across several other defined public health essential services, including strengthening and supporting and mobilizing community partnerships, creating, championing, and implementing policies, plans, and laws, enabling equitable access, and building a diverse and skilled workforce. And I'm sure the case can be made across all the services that are listed here as well. And how we work with data is clearly not just the work of our learning and evaluation teams, as we've seen. Therefore, it is incumbent upon all of us to work to acknowledge on how to recognize the importance of equitable data and the role we all play throughout. As we move along in our presentation, I encourage you all to think about your role and where you fit along the data system or the data lifecycle, and how your role can continue to advance equitable health and racial outcomes.
Thank you, Anna, for really elevating where we see these critical intersections across public health functions. But I do want to take a moment to elevate some of the gaps in public health data systems that ultimately can hinder advancing health equity. This includes how departments are able to or choose to share and report out data and findings, the types of sexual orientation and gender identity data that's being collected, lack of race and ethnic disaggregated data, for example, Native Hawaiian, Pacific Islander, and Asian categories, a lack of granularity at the geographic level, and an inability to share findings at the neighborhood level, or an inability to conduct systematized assessment of the social drivers of health with population health outcomes across communities. And a spoiler alert, the Healthy Places Index can do many of these things. So we've spent a little bit of time now talking about the power of data and how we use it. And I just outlined a few of the gaps and pitfalls that we might encounter across data systems and for public health more explicitly. So we are going to provide a real definition for what we mean by an equitable data system before we move into our recommendations and promising practices. And I'm going to share a definition that comes from the Robert Wood Johnson Foundation that we think really strikes this critical balance and even speaks to sort of broader systems and what it looks like to really embed and be rooted in equity. So I think you'll see much of what you just shared in the definition that I'll share with you today. And rather than limiting us to just thinking about what is an equitable data system, we're really expanding beyond to think about a modern, transformed, equitable data system. And we view this as one that is accountable to and reflects the perspectives of local communities and diverse populations, including people of color, immigrants, people with disabilities, and the LGBTQ+ community. This system must be sustainable and fully integrated with healthcare and other sectors that are really driving health by linking data across multiple sectors and at multiple levels, and providing data that are disaggregated, comprehensive, and timely. It should move from a problem-focused to a solution-focused analysis and really have the capacity to provide the knowledge needed to optimize health and well-being for all people. We also see this system needing to provide the tools to address racism and racial and ethnic and other social disparities. It should facilitate restorative systems that respect all communities, including the sovereign right of tribal nations to govern their data and ensure that they have access to it. We also see the critical importance of protecting individuals' privacy and security and guarding against unintended consequences. And as I said before, we really appreciate this definition because we feel it's quite comprehensive and is very action-oriented in terms of how it frames the challenges and solutions around our approaches to data. So as we're all moving forward to improving our equitable data practices, we want to uplift a framework that we think can serve as guideposts along your journey. And this framework you see here is from the San Diego Community Information Exchange, or CIE. And it outlines different data design types from the far left that is defined as predatory engagement to the far right, which is defined as a liberatory model. And each step along this spectrum demonstrates how the system is oriented toward the populations being served and does not necessarily reflect the static nature of a data system, and I think may even represent a small glimpse into the larger data system across your local health jurisdiction. And these developmental stages allow us to recognize where we are and also set goals for where we can go together through conscious and collective practice, which, as we know, is key to transforming any system in which we're working. So I'll walk through the kind of key design types just to give you a sense of what's included therein. So the first design type is predatory engagement, where there are profits from systems of oppression. So data from the community is treated as a commodity and used to demonstrate a return on investment to obtain more grants and contracts for a program or system. There may be a lack of consent, or community members are unaware of how data is being used, and there's a poor structure of accountability, if any. Moving one step to the right, the next design type is passive engagement, which largely ignores oppressed populations. In this design type, the institution collects data as part of service, may hold it indefinitely, and uses it beyond the explicit purpose for which it was collected. The next step to the right introduces the savior-designed engagement type, which may exploit oppressed populations for secondary gain. An example is what this might look like is developing a program in service to a particular population, but no one within that group was engaged in the design of the data collection methods. There may be consent and data collection practices, but often through a sort of extraction-based methods, such as a prerequisite for services. And accountability is set by the institution, but the community bears the responsibility for inputting data into the system. The next design type is called ally-designed engagement. And in this, we start to see some important shifts in which the institution or system is listening to community feedback to support institutional goals and objectives. And this can look like after implementing an intervention, community members are invited to provide feedback on program implementation with a real focus on supporting the institution's evaluation and listening efforts. The data narrative or insights gleaned from the data are set by the institution, which may often highlight community deficits as opposed to community assets and solutions. The next design type is equity-empowered engagement, which really strives to dismantle systems of oppression to primarily support the people who are oppressed. In this design type, a program may have community-identified goals and objectives and acknowledges and addresses systemic barriers. Data collection is requested but not required for services, and community members have an opportunity to understand how data are being used. Data is used by community for advocacy to meet their needs, and data are used to address root causes of inequities, and again, strive to dismantle inequitable systems, processes, and practices. So people have the power here to hold systems accountable for outcomes. And the final design type on our far right is called the liberatory model, and ultimately seeks to eliminate forms of systemic oppression as a means for the people who have been oppressed to have power, self-determination, and reparations from past harm suffered. And this design type really enables collaboration with multiple stakeholders, authentic community engagement and community ownership, and data is requested, not required, and community members have the power to opt in or out of contributing data at any time. And data are really used to address community identified problems. The program addresses resource gaps while calling for advocacy for policy change to address these systemic barriers and root causes like systemic discrimination, disparities, and racism. So I know that was a lot of information sharing on this particular slide, but I think the link to this framework has been dropped in the chat, and I really encourage you all to spend a little time with it and really reflect on these different systems and structures. But I do want to share sort of one more reference point for all of us, especially, as Delia outlined, the majority of folks kind of indicated they're in this passive engagement space and maybe doing some work in the savior-designed engagement and ally-designed engagement. So kind of falling in the middle here, which makes sense, but still with the majority in the passive engagement phase. And so I just want to share with folks that you're not alone by any means in this, not in our region, but even at a national level. So what I'm sharing here is information from a national survey that included responses from more than 400 survey participants who were asked about the involvement of people with lived experience in various stages of the data lifecycle. And the majority of these survey participants came from either nonprofit sectors or government or public institutions, so fairly reflective of all of us here in this space today. And as you can see, overwhelmingly, people with lived experience were not actively engaged or making decisions within multi-sector data initiatives, as indicated by the blue bars there on the right side. And just to uplift the sort of critical importance that data infrastructure and solutions, there has to be local grounding, and they must be informed by and supported by local community in order to be meaningful and sustainable. And advancing these practices and systems changes requires a lot of trust and transparency, and I think also empathy and humility across the data system. So I, again, really appreciate everyone's willingness to share and reflect on where they are. And I'll pass it back to you, Anna, and also if we have any time for anyone to share their thoughts as well.
Thanks, Savannah. I feel like there might be some, thoughts brewing as folks are sort of ruminating. You might have more chance in the breakouts as well to hear from folks. But as always, you want to make sure that we open up space for you all to drop your thoughts in the chat a little more cohesively, or just raise your hand as well at any time during our presentation. So in reviewing the framework, we were really inspired by the design types that Savannah had elevated, such as ally, equity, and liberatory data design types. And we wanted to frame and add to our recommendations that we're elevating here today that build upon, our institutional knowledge around data into the recommendations on how to embed equity into your local data systems and work. And so we've divided our recommendations into 4 somewhat sequential categories, which are around data collection, data analysis and interpretation, the reporting of data and findings, and then going into data into action. And before we jump in, I also just want to quickly acknowledge that this is not an exhaustive or representative list, but we feel that it is really elevating some of the primary stepping stones that will build a foundational bedrock of equitable data practices and systems for your own local health jurisdictions, as well as across data systems, both statewide and potentially nationally as well. So the first recommendation is around how we do our data collection. And we want to talk about how to expand and improve the collection of demographic data. And in order to properly identify health inequities in our communities, we must do better to collect and authentically partner and engage community members in the survey design and data collection of disaggregated data. And that includes by race and ethnicity and community of residence, but also by other factors that privilege certain groups over others, such as age, gender, identity, sexual orientation, and occupation. I want to highlight that we specifically need disaggregated data by race and ethnicity. And if we continue to only look at large racial ethnic groupings, we may miss health inequities occurring in smaller populations. For example, we can think about Native Hawaiian and Pacific Islander populations that are categorized within the larger Asian racial ethnic category. And I'll go into more detail on that in a later recommendation on how that relates with COVID data. And then similarly, I also want to highlight that we need geographic data at a fine spatial scale or on a granular level. Collecting data by state or even by county of residence fails to address the heterogeneity of that state or county and doesn't allow for identification of neighborhoods most impacted, which is why geocoding addresses to census tracts, for example, is an important way to do this. And working to expand and improve collection of demographic data can help us identify small populations. There are currently legislative efforts to strengthen this as a standard practice. And currently data tools like the Healthy Places Index can support this level of analysis. Secondly, we want to think about how we can build trust and share power to ensure local community voice is represented. We want to share the motto, nothing about us without us. which is a slogan that has deep roots in disability activism, but has also been used in health equity work to emphasize the importance of full and direct participation by community members in any policy or work that will directly impact those communities. Institutionalized partnerships, power building, and bidirectional feedback ensures that cultural sensitivities are honored. We avoid extractive practices, and we prioritize a collaborative bottom-up approach to public health. We'll include a few links in the chat on how the Achieving Resilient Communities, or ARC initiative that is happening in Ventura and Kern County is partnering with farm workers, and in particular, Indigenous farm workers, to share their stories and experiences alongside the data that they're also collecting. And lastly, we want to elevate how qualitative and quantitative data can be used to uplift community voices and be a powerful tool for storytelling. Qualitative data collection can be used to really humanize the data by adding personal narratives, sharing lived experience, and even through things like photo voice can help contextualize burgeoning and historic community inequities. Gathering and incorporating these elements here can strengthen the analysis, reporting, and the action steps taken further down the road. Our next recommendation is around how we analyze and interpret data. Building on what we shared in our recommendations for data collection, we also want to elevate the need to ground truth your findings and analysis. Doing so can unveil what is potentially being masked or unsaid by the numbers. And there may be also different interpretations or actual root causes that are driving the data, and ground truthing can be one step in the larger system of a partnership or engagement with community members. And this can really bring healthy challenges to our understanding and notions of the status quo. Secondly, we want to elevate disaggregation of data again. And not only is it important to collect the data in a fine disaggregated scale, but we must also analyze at these smaller, more granular levels as well, including race, ethnicity, age, gender, etc. Community leaders and partnerships with them in the data process can inform which groups to focus on and highlight in an added level of analysis, and how to best disaggregate the data in the analysis and interpretation stage. And lastly, we must understand the perspectives and the biases of our experts and how they may influence our data analysis. Data analysis and interpretation should be transparent, intentional, and untethered to a single analyst's experience or perspective. For example, public health critical race practice utilized the tenet of critical self-reflection and asked each researcher to complete a self-questionnaire that assesses their assumptions related to the study aims. And this type of implicit bias check could be done across all stages of the data lifecycle. And it can really ensure an objective, equity-focused perspective to support the community and program goals. Our third category of recommendations we want to elevate is around practices on how we should be reporting out our data and findings. First off, it should be prioritized that data are reported at actionable community level geographies, and preferably at the smaller census tract levels. And again, if we've been able to collect disaggregated data, we can utilize that to support our findings and ensure that we are unmasking potentially hidden inequities. So coming back to that example that I raised earlier about Asian and NHPI categories, if we're looking at COVID-19 infection and mortality rates across the Asian population, we may see that their numbers are lower than other racial ethnic groups. However, if we further disaggregate this category, we can clearly see that Native Hawaiian and Pacific Islanders have some of the highest, if not the highest, infection and mortality rates across all racial ethnic groups. And this would never have been revealed if we hadn't had the data to see it. You should also aim to provide accessibility to the widest audience. And this includes publishing data in machine readable formats, compiling online public-facing data dashboards, and compiled in easy-to-read reports for the general public. And I would also include in the languages that are considered threshold languages or languages of importance in your community as well. And strategies can also include utilizing qualitative data, which is an important and critical way to elevate community voice. And it can also look like creating an interactive story map or public-facing data dashboard, which we talked about. Data should also be updated as frequently and transparently as possible, particularly in public health emergencies. Automated processes for data updates and publication can be developed and shared between state and local health jurisdictions in order to streamline data reporting. And lastly, I want to underscore that it's important that local health jurisdictions are also supporting the public reporting of disaggregated data. This can support trust building with CBOs that often do not have the resources, time, or expertise to collect their own data. And moreover, these data serve as critical resource for the communities we serve and partner with. And part of our public health responsibility is to remain accountable, but to also support and put the data into the hands of the community and as stewards and owners of the data as well. And finally, we want to ensure that we are using the findings from our data collection, analysis, and reporting into action. And this can take many forms, but we wanted to highlight just a few. The first is to mobilize your community into community data stewards. This can look like hosting ongoing trainings and building the capacity of local CBOs and FBOs, or faith-based organizations, to become data ambassadors. By helping increase their own understanding, they can increase their sense of ownership over the data and move toward action in their advocacy and in their campaigns, and can become critical partners in the collection and analysis as well. Secondly, we can look to see how we can make the explicit connection of how to utilize data to inform policy change. This can come first by identifying the policy change needed and then collecting the data to support that policy, or policy change can be informed by what we see and hear from the quantitative and qualitative data. The California Healthy Places Index is one example on how to link direct data to a policy change. The HPI platform includes a comprehensive library of policy action guides to support building policy at the intersection of health, equity, and data. And lastly, we want to elevate the concept of creating health equity metrics. Excuse me. We envision health equity-like metrics as a critical component in a multi-pronged strategy for truly addressing equity. A health equity metric allows you to calculate rates of disparities across the selected social driver of health factor. For example, the state of California used this model to create the statewide blueprint health equity metric in response to the COVID-19 pandemic. The California Department of Public Health realized that it wasn't enough for counties to improve case rates in their most resourced, materially advantaged communities. They had to make sure that no community was left behind. Therefore, counties couldn't roll back control measures, reopen businesses, unless they saw improvements in case rates across their entire jurisdiction. Specifically, lowest HPI quartile communities, those with the least healthy community conditions, had to be within a certain range of the countywide positivity rate in order to move forward. Funding and technical resources were made available to help counties achieve this, and CDPH published the Health Equity Playbook and offered TA to support. So that was a quick overview of the recommendations we wanted to elevate, and we hope that these were sparking and generating ideas on how you can embed equitable data practices into your own data systems. And I'm seeing a lot of conversations in the chat, so please stop me if we want to pause to highlight something. But, you know, I also want to mention by now, you've also heard that California Healthy Places Index mentioned several times. So we're going to take this opportunity to hand it over to our colleague, Colleen, with the Public Health Alliance data team to share a little bit more about how you can use this powerful mapping and data tool to advance your equity efforts locally, which will then lead us into our first breakout activity.
All right, thanks, Anna. Yeah, I'm super excited to be here today to share a brief overview of the Healthy Places Index and review some of the key features of the platform that we feel can support and advance this really important work of developing equitable data systems. First, I want to, First, I wanted to start off by giving a little bit of background of why we created the Healthy Places Index. Decades of research tells us that our life expectancy and well-being are tied to the community conditions in which we live, which includes the existence of racially driven laws and policies. We also know that access to social conditions that support health, what we call the social drivers of health, like education, good job opportunities, and healthy food and water, vary drastically by neighborhood for a complexity of reasons. More specifically, we know that systemic racism is a major barrier to health, and communities of color continue to disproportionately experience negative economic, environmental, and health outcomes due to racist policies that are embedded in our systems. So our team at the Public Health Alliance operates with the understanding that in order to create lasting systems change, both race and place must be recognized and understood. Next slide. So that's why we created the Healthy Places Index tool, which launched in 2018. The HPI was expressly built to highlight community assets and strengths using a positive frame that can be mobilized to implement solutions. And it maps neighborhood level data on conditions that drive health, layered with racial justice data and resources, and provides community-specific policy recommendations to advance health equity. Next slide. The HPI advances health equity by providing data and policy recommendations to compare the health and well-being of communities, identify the community conditions at the neighborhood level by quantifying the factors that shape health, and support communities and leaders to turn data into actionable solutions to advance equity. Essentially, we provide communities, leaders, policymakers, foundations, advocacy groups, academics, and other stakeholders with tools to identify inequity, prioritize equitable investments, and strengthen community voices with sound validated data. Next slide. Oh, sorry. So we do this, the HPI scores and compares neighborhoods across the state based on how healthy the local social conditions are. The tool, specifically the new HPI 3.0, does this by evaluating the relationship between 23 key social drivers of health tied to life expectancy at birth. The HPI produces a score representing the relative rank of community conditions in a selected area, which can be filtered by a range of geographies, including census tract, zip code, city, unincorporated areas, congressional districts, and more. And it compares it to all other such areas in the state. And our data and policy recommendations are organized by 8 key policy action areas, including economic, social, education, transportation, neighborhood, housing, clean environment, and healthcare access. So who can use the HPI? Anyone. We made this platform free, accessible, and easy to use in order to ensure fair and open data that is available to all. And we believe specifically the following sectors could really benefit from what the HPI has to offer, including state and local leaders, government agencies, school districts, the media, community-based organizations, and many more. Next slide. Oh yeah. So I wanted to take a step back, and I think Tracy mentioned this earlier, but since 2018, the HPI has become a go-to data tool for hundreds of state and local government agencies, foundations, government advocacy groups, hospitals, and many others. And it's been adopted for various uses, addressing critical community needs like active transportation, affordable, stable housing, food security, climate resilience, and the health equity metric that influenced COVID funding and support in California. And we're proud to say that the HPI has been used to inform the distribution of over $1 billion to community-focused investments, including $272 million during the COVID-19 response to communities that were most impacted by the pandemic. Slide. And before I dive into highlighting a few select new and enhanced features in our current HPI data and mapping tool, I wanted to zoom out for a moment and talk about our race and place framing that we've implemented throughout our HPI 3.0 tools. We know that factors of both race and place are proven to acutely impact health outcomes, and we were really intentional about enhancing these features of race and place in our update. And the ability to analyze the impacts of race and place in the HPI 3.0 platform affords insight on the specific needs and conditions of each community. And that additional insight allows you to develop more equitable interventions, programs, and allocations of resources and funding. It also ensures that these resources are scaled appropriately to each region. And these enhanced data and tools help communities better advocate for their own needs. So with that important context, let's just look at a couple of these new features and enhanced functionality. The first feature we want to demo is our filter by race and ethnicity feature, which allows you to find priority communities based on race and ethnicity. This level of detail on race, ethnicity, and national origin is important, especially if you belong to a community-based organization or advocacy group that serves a specific or small population. We know just how difficult it can be to find the neighborhoods where your population lives, especially if they're small or geographically dispersed. And that's exactly what this feature helps with. Next slide. So to use this function, you click on the filter by race ethnicity in the tools menu, and you'll see a list of race ethnicity groups where you can select specific groups. Here we choose Hmong, and the map will automatically filter to only show neighborhoods with that population. At the bottom of the panel, you can also adjust the filter threshold to see larger or smaller communities. And I've changed it to show neighborhoods where there are at least 400 people who identify as Hmong. If you work with this community, this is a really quick way to narrow down the places that you might want to focus your outreach, for example. Next slide. So we also have a compare data feature, which gives you the ability to track improvements or declines in a community over time. And this is key for checking progress towards community or health goals. For example, the city of South San Francisco's Racial and Social Equity Commission identified preschool enrollment as an action item for change and wants to explore the possibility of implementing universal preschool services. And they propose using HPI to track preschool enrollment, among other indicators, to measure the city's progress. So if we wanted to do that now and see how preschool enrollment changed between HPI 2.0 and 3.0, we could do that. Next slide. So to do this, we would click the compare data function in the tools menu. We'll set indicator number 1 to preschool enrollment and use the select years of data. I'm gonna wait for it to catch up. Yeah, use the select years of data, drop down to pick the earlier time period. And then we'll set indicator number 2 to preschool enrollment. And there's no need to adjust the years of data because it automatically displays the latest time period. Now we have 2 maps side by side, and we can see how preschool enrollment has changed. You can even click on neighborhoods to directly compare enrollment between the 2 time periods. Next slide. And finally, I want to share one of the features that we're most proud of, which is our indicators stratified by race and ethnicity. We know that health outcomes like low birth weight in infants can vary significantly by race ethnicity, and community conditions can too. Seeing how community conditions vary by race ethnicity can also help hospitals and healthcare organizations understand the differences in health outcomes that they see in their own patient populations. In HPI 3.0, we provide disaggregated data for over 30 indicators, including many of our own HPI indicators. So let's look at that in action. To access our disaggregated data, you first select View Indicators in the Tools menu, and any indicator with the Group of People icon next to it is available disaggregated. You simply select that indicator to load it on the map, and then choose a race ethnicity from the drop-down menu here. And you'll see the map reload to show this indicator by the selected group. All right, and with that, I'm gonna hand it back to my colleagues to lead you through the breakout group activity. Thanks for the opportunity to share these new features of the HPI, and we really can't wait for you to try it out.
So I'm so excited to share that today we are being joined by Minister Deborah Williams, who is the founder and CEO of Building Resilient Communities. To share a little bit about her, Deborah birthed BRC and its various programs based on her strong faith and over 25 years of experience as a management consultant to large and small community, public, and private organizations where she provided training, business coaching, team building, and strategic planning services. Deborah has a bachelor's degree in business management from the University of Phoenix, a bachelor's degree in biblical studies from the Bible Institute, and a certification in management effectiveness from USC. Along with her busy work life, Deborah has been happily married to Russell for 35 years. They have 3 children, 14 grandchildren, and 1 sweet grandchild. She is an avid knitter, which benefits her grandchildren and friends. So Deborah, we are so excited you're here. I'm going to hand it over to you. Thank you.
Thank you so much. I have to update that a little bit. My husband and I have now been married 36 years as of the end of July. And I have a brand new great-grandchild on the way who should be here. She should be here within the next 2 weeks. So that means I am at night busy making a blanket for her. I am knitting at night. So that's my stress relief is knitting. You know, I can't crochet because if I do, you know, things start this big and they end up this big. So I'm really excited to be here. I want to thank you for inviting me to share some information today. And like all of you, this has been such a whirlwind 2 years, right? That's how we feel. And so I'll share a little bit with you about what we have been doing, who we are, what we have been doing, as well as kind of where we're going, what we're thinking right now. So if you would advance the slide. So this is more of my formal agenda. I'm going to talk about taking data to action, partnerships, and the importance of those partnerships, and the fact that it really does take a village, and then some lessons learned. So I'm going to try to speak fast so that I stay within my time frame and we have lots of time for questions. So next. If you're not familiar with building resilient communities, we've been in existence really since 2012, and we work across Riverside and San Bernardino counties. So we work in the inland region. I'm trying to get accustomed to not calling it the Inland Empire anymore. It's the inland region now, so we really can change. So what we do is provide really disaster preparedness, response and recovery, be it education, resources, and tools. I'll let you read our mission statement because it's all about equity for us. That's where we are now, where we've always been, and where we're going. So next. We have 4 primary programs that 3 of them are all about preparedness, disaster preparedness, and 1 is for response. The first one is the Ark of Safety program, and that's where we work specifically with the houses of worship, any house of worship, doesn't matter what faith it is, to help them prepare, because we know that when the fire is out and the fire department leaves, they're left to pick up the pieces in the community. Same thing with if it's an active shooter event, when the police catch the bad people, they're gone to the next incident. And it's a lot of times the community-based organizations and the faith-based organizations that are picking up the pieces. We also started working with small businesses, in particular BIPOC community businesses, because they are not prepared either, and they don't have the resources to get prepared for a disaster. And we know that when a major disaster strikes, it's about 50% of the businesses that just simply go away because they can't survive. And we've even seen that with COVID. our Arc of Safety Youth program. It's kindergarten through 12th grade, and it has an element of disaster preparedness for the youth as well as their families, but it's also about volunteerism and career development, and specifically careers that are typically not going to require a college education. And so we work with a lot of students who have no desire to go to college, but they can have a good career. So that's our Arc of Safety Youth program. And then the response program is our Christian Disaster Relief Coalition. And that's where we work with many churches in the area. We get them trained, vetted, prepared, for when a disaster does strike. They know what services they can provide, and we serve as that liaison and point with the government to get them out in the field. We take responsibility for them and get them out in the field to help with response and recovery. And one of the areas that we really work on with the CDRC is emotional and spiritual care. So that's the 4 programs that we have. Next. And then, of course, then came COVID. We all talk about before COVID and after COVID. So we still do all of those programs if necessary. We do work on them. We're still praying there's no earthquake, please, no earthquake, no earthquake, no earthquake, right? But just like Lewis Carroll or Alice in Wonderland, if you don't know where you're going, any road will take you there. So when COVID hit, we realized that we needed to start looking at data. We really needed to figure out what was going on. When we specifically got the call from Riverside County Public Health, their equity team, and said, can you come and help us to make sure we get shots in arms? And of course, they didn't say it that way, but that's how I say it, to get shots in arms in the African-American community. We said, okay, we're there, we'll help. For us, it's a response, it's disaster response. I remember the days when we used to do tabletop exercises, and I remember doing one actually in Riverside County, and it was based around a pandemic. And we all sat around the table, and it was almost like, oh, we don't know what to do. We don't know what we would do. This doesn't make sense. Yeah, this is fun. And then COVID hit. And our whole world's changing. So let's talk about how we use the data next. So the first thing we did was we began to use the HPI, all of the wonderful work from Public Health Alliance. We used all of that work as a data point, a place to start. Where do we start? And our focus was the African-American community. And so we started asking Public Health Equity Team, Riverside County Public Health Equity Team, give us the information. We don't even know where do we start with the African-American community. And so we were really unhappy when on March 4th, we saw the numbers for the African-American community as far as being vaccinated, 9.3. Well, all of us are really kind of overachievers. And if you remember the old thermometers that you used to have when you did some kind of a campaign, well, we wanted to see the numbers go up. So we used the data as a starting point. And then next, we also used the data to figure out what geographic areas did we need to work in. Where are the African Americans? Where are the people that are not getting vaccinated? And we started meeting weekly every Thursday from March of 2021 up until last month. We were meeting every Thursday morning from 9 to 10:30. So consistency. We did not let this thing go. And every week, Public Health Equity Team would give us the data so that we knew where we were. So we looked at defining our target areas. Where do we need to do our outreach? Where do we need to set up clinics? Those kinds of things. Next. And I will say without this data, it would have been, you know, just a gunshot, you know, just a approach. You know, we really wouldn't have known, but we could be laser focused on where we needed to be. And so we were also looking at, you know, by age group, all kinds of data. We cut this data in every way that we could to find out where we need to work and where do we need to move. You know, can we move over here now? Okay, they're doing better. Now let's go over here. And so you see January 26th of this year, if you look at the African-American line there, you see that we were up to 52.3%. Big difference between 9.3 and 52.3%. And it's just because we were sort of bound and determined that we were going to get shots in arms. But there's another reason that we did the data. It was for our own self-care. You all know this has been difficult work. There's been vaccine hesitancy. There's, you know, been all kinds of things happening as to, and reasons why people don't want to get vaccinated. And so every week we could look at this and see, like that old thermometer, are the numbers going up? Did we get 1% more? Okay, we're doing okay. We're all right. And so we actually used it as our own self-care as well. It made us feel better to know that people are hearing us, people are listening to us. So that's another way to use the data. Next. We took this personally. We really did. You know, it's like, this is our community and we're going to get shots in arms, or somebody, or they're going to tell us why not, you know, kind of thing. And so you see here the information, 57.2%. This was January 25th of this year. And not that we don't care about the other ethnicities and groups, but we were brought in specifically to be laser focused on the African-American community. And I would say that was probably, just like with the Latinx community or with the indigenous community, the Asian Pacific Islander community, that was a powerful statement by Riverside County Public Health, because they were willing to say, we need you to focus on your community. They were willing to do that, and it made a huge difference. So we began to use the data to show progress as well. Next. So it was really important for planning, not even beyond what I've already talked about with the geographic areas, the age groups, or, you know, whoever it may have been. But this slide is one that we saw that we said, okay, we need to do something about that. We saw that we had more African-American women getting vaccinated than men. And so we specifically started doing things to make sure that we were reaching African-American men, going where they are. And I'll talk a little bit about that in a minute. Next. The other part, not only was the data key, but then also developing partnerships. And so one of the things that we did, because Building Resilient Communities does work with the faith-based community a lot across the inland region, One of the things that we knew that we could do was reach out to all of the houses of worship, especially the African American houses of worship in Riverside County. We already knew them. And so, and we speak their language, you know, so we could probably easier than Riverside County Public Health go in and talk with them, just simply make a phone call and say, hey, are you willing to have a clinic there? So we began to serve as a liaison between the African American faith community and the Riverside County equity team. And so after a while, it got to the point where they actually could call them, because now they've built a relationship with the African American churches. And, you know, but we had to kind of, you know, help that introduction, and they began to know that they could trust public health, because now they've worked with them. We also, a really important thing that started in the very beginning in March of 2021, I started hearing about all these different groups that were trying to help with the COVID response in the African American community. And I started calling them or emailing them and just saying, hey, here's what we're doing. Let's collaborate. Let's join together. There's only so many African Americans in the inland region completely, and in Riverside County. And if we're all having events or we're all doing town halls, then we're splitting the community and maybe not being effective. And so an amazing group of agencies came together, and we're still together today. And I'll talk a little bit more about that. And then California's VA 58 got involved and became one of our partners. They're a strong partner with us. And then we partnered with the houses of worship, the schools, the businesses, all of the different community groups to get PPE out to people, whether it was home test kits or, you know, mask or hand sanitizer, and we're still giving all those things out. I just heard from somebody the other day that they went to Walmart to try to buy N95s or KN95s, and Walmart no longer has them, and Home Depot no longer has them. And so the free stock that we got from the counties and from the state, we're still giving it out because people are still wearing masks and they are still using hand sanitizer. So we always provide education packets, and those education packets have information on COVID, and now they have information on the therapeutics, but they also have disaster preparedness information as well. Next. So we like to think it takes a village. And this is one of the things that we really learned from emergency management, because our focus is around disaster preparedness, response, and recovery. We know that there's the whole community approach when you start talking about a natural disaster. And so that's the concept that we have brought into COVID response and anything that we do with public health. Public health can't do it by themselves. We can't do it by ourselves. We need each other. Businesses can't do it by themselves. It takes a whole village. And so when you look at, this is just some of the agencies that are a part of our African American Collaborative. You see, it's not just faith-based organizations or community-based organizations. You see there's government in there. You see there's, you know, all different kinds of agencies. Education, California Baptist University is there. UCR School of Medicine is there. Moreno Valley School District is there. And so we all came together to collaborate, and we still are doing that. Next. So here's the mission of the African American Collaborative. And very much like in disaster preparedness and response, you know, when you can come together with a common cause, we say one team, one mission. then you can capitalize on the knowledge, skills, and abilities and experiences of everybody that's there. You can share information and resources. As an example, we decided one group would take responsibility for doing town halls instead of 3 or 4 different groups trying to do town halls. We said, okay, you're the lead for the NAACP, you're the lead for town halls, and we're all going to support you. Okay. And same thing, education campaigns, whatever it may be. We have one group, the Black Chamber of Commerce for Riverside. They decided that they would take responsibility for reaching out to the barbershops and the beauty salons. And we said, okay, nobody else is going to do that. You do that, you take the lead, we've got your back. And it wasn't just, we'll be here if you need us. No, we were really involved in helping them do it. And so we also know that there's limited resources. One of the things I'm sure you are well aware of with community-based organizations, there's limited funding, and we're a lot of times fighting for the same funding. And we said, nope, we're not going to do that. We're going to capitalize on the existing resources that are available. And if it was an agency that wasn't getting funded through public health, but we building resilient communities were getting funded, we could say, okay, we'll pay for that. We'll cover that cost because it needs to get done. So we share everything. Next. These are some of the areas, like I mentioned before, where we do focus. This is still our current focus. I would add on to this list now, I would add long haul COVID, and I would also add mental health, and lastly, mpox, monkeypox. So next. So this is one of some of the things that we have done. One in particular, the pastor's toolkit and orientation. We know they are trusted messengers, and people are constantly asking their pastors questions or their faith leaders. So we created this toolkit to educate them so that they also have resources and tools to provide to their congregants or anybody who's asking them questions. And you can actually download this from our website, and we've updated it. And then the Coachella Valley equity team, who is really focused on Hispanic Latinx communities, they asked us if we would convert this into Spanish for them. And so we worked with the VA 58 team, their marketing and communications team, to do that. And we made sure that it was culturally relevant for them. So where ours, this red, yellow, green, those are normal, regular colors, acceptable colors in the African-American community, but not so much in, say, the Latinx Hispanic community. And so the new one looks totally different. Next. So here's some lessons learned that I would share with you. I've already said trusted messengers. Use your trusted messengers. Your community-based organizations and your faith-based organizations are already embedded in the community. They already know the community. They work with them on a regular basis. They are trusted messengers. And then people need to see people who look like them. That's one of the other big things that we did. We started asking public health, when people come to the clinics, they need to see people who look like them. And then make it convenient. Go to them. Go where they already are. We started having events, and we still do, around annual community events. If it's something for Juneteenth, we're going to have a clinic there. go where they're already there, right? Backpack events for back to school, go there. They're going to be there because they want those backpacks. Have your clinics there. I've said it takes a village, and the other piece is combine the data and the culture that you're focusing on. So those are the lessons learned that I would have. Let's see, is there something next? Okay, and just lastly, we are continuing to have the African American Collaborative. We now have expanded it. So we changed the name to African American Equity Collaborative Inland Region. And where it was just Riverside County Public Health that was providing data to us, now every other week, we have, and this might be a surprise to Salome, I know she's on here, we have now invited San Bernardino County Public Health to participate in those meetings so that we have a balanced approach. One of the things that we know for sure is people may live in one county and they may work, play, and worship in the other county. And so we cannot have a Berlin Wall between our two counties. Okay. And then the last thing is the Arc of Safety Community Resiliency Summit. And a lot of what you've been talking about is exactly what we are starting to do. You see that image of the iceberg? We realize that everything that we have been doing, even in disaster preparedness, has been above the surface. And sometimes it feels like we're addressing symptoms. And we now are saying enough is enough. I really honestly just am tired of writing, we serve vulnerable and underserved populations. I'm tired of writing that. And so my question was, why are they vulnerable and underserved? Let's put on our scuba gear. Let's take a deep dive under that surface and figure out what are the barriers, what are the systemic issues, what's making them vulnerable and underserved, and let's go after those things. So that's where we are, and we're asking people to join the movement. Our next event is going to be on January 12th. If you want to put that date on your calendar, we would love to have you join us, because we are all about Nike, just do it. and my other saying is, let's get her done. So we don't have a lot of time to talk. We're just about, let's roll up our sleeves and let's help the community. And I think that's my last slide. All right, thank you.
Great, thank you so much. I really appreciate where we sort of landed and where you left us with your presentation of, like, we need to find those structural root causes of what is impacting the health outcomes down the line. It has been unfortunately carried over generations and legacy. So important that we're elevating and lifting that. So thank you. And thank you for everything that you shared. I shared a note. I'm going to stop sharing my screen so that we can see everyone. I shared a note in the chat that if you have questions from Minister Deborah, feel free to drop them in the chat, or you can raise your hand and ask them by unmuting yourself. But I didn't see any questions come in right now, so I'm going to go ahead and kick us off with one that came up for me. And one thing that you elevated in your when you talked about the partnership with Riverside during the COVID response was this idea of the consistency in the partnership with the local health jurisdiction. And I was hoping you could talk a little bit more about what that looked like in terms of how that partnership worked, what was Riverside providing, and how are you providing feedback or asking for requests with Riverside for how this partnership was enduring and ongoing.
Yeah, it was and is amazing. It's ongoing. And I think the first thing I would say is, I think Riverside County had a lot of courage. And I believe that it takes courage to do equity work. And I want to really applaud Kim Sawatari, and Salome and Robin Bishop and all of the people that we worked with, because partnership really started with them fighting for us. And when I really mean that, they have not really said the things they've had to do, but they trusted us. And because they trusted us, they went to bat for us with the rest of public health when people didn't always believe in equity. And I know that they did. I told them so often that they were at the point of the spear. Even with our agency, Building Resilient Communities, we've only been around since 2012. We are a small staff organization. They had never really heard of us except one person, which was Robin Bishop, because she and I have been boots on the ground with all the disasters across the inland region. And when Robin said, you need Building Resilient Communities, I will say people were like, no, we don't. They're too small. I'm telling you, some of those small nonprofits in your area are mighty. They're mighty. And when even knowing that they were supporting all of us and fighting for all of us made the partnership even stronger. So they attended our meetings every week. They gave us the data every week. If we said we need it cut this way, they gave it to us. If we said, hey, the clinics have to change. Nobody wants to go to a doctor's office. Nobody wants to, let's stop all the doom and gloom. Let's get some balloons. Let's get some music going. Let's have some fun. This is all about life. Even in the African-American community, we don't have funerals. We have homegoing celebrations. So it was a matter of listening to us about our culture and saying, okay. And that meant they trusted us. So that's the level of the partnership that we have with Riverside County Public Health.
Thank you so much. I have some questions that sparked from that, but I see that we have a question from Daniel in the chat. And Daniel, I want to invite you to come off of mute and share your question if you're able to.
Sure, no problem. Thank you, Minister Deborah. This is amazing and really inspiring. I would love hearing, because I really appreciate it.
Daniel, I think
Is it
you
off?
cut out.
Can you hear me now?
Yes, I think you might want to start over.
Sorry, Minister Deborah, that was amazing. That was amazing, and I guess I wanted to spurred. Oh,
Yeah, so I'll read it on Daniel's behalf. This is Ryan Daniels. I'm Daniel's colleague here at the City of Pasadena Public Health Department. So we wanted to know, he said, would appreciate hearing how you are pivoting this data sharing and strategic partnerships to efforts that tackle the social determinants of health. I mentioned at the end that go well beyond COVID vaccination and will outlast publicly funded COVID-centric equity efforts.
Yeah, that's a really good question. And we started seeing that a few months ago and started making that change. And so I think we're formalizing our collaborative a little bit more. Right now, we're in the process of developing a vision, a mission, core values. We're kind of doing strategic planning, but we've already pivoted in some ways because we're still doing COVID, but now we're doing impacts, right? And I will share this. It's very different, and the summit is going to help us address the social determinants of health. That's the purpose of the summit. And we are going to have a report that's coming out of the summit that we did on September 13th that we call the Roadmap to Resilience, because we put everybody, we had speakers, we had panelists, but we put everybody in breakout rooms and asked very specific questions so we can give everybody a copy of that report. And that's how we're turning the corner to address broader health issues. But I really want to talk about MPOX for just a minute. We did amazing work, all of us, with COVID. We figured it out in all the different counties. And I am actually sad to see that, at least from my perspective, those lessons learned are not being transferred to MPOX response. And in a few ways, there's I know that MPOX is hitting the LGBT community hardest right now, but I'm going to encourage you to think about it in two phases that have to happen at the same time. You have to get shots in arms or wherever they're putting them for MPOX, right? That's response. But if we ignore the communities that do not identify as LGBT and prepare them, then I'm concerned that we're going to have a really big problem. And so when I see vaccinations going to one primary group, and I see these other groups that are getting MPOX, but they are not getting vaccinated, that's not equity. So because I'm faith-based, this is what I would say to you, that don't just focus on the LGBT community, because you have people sitting in houses of worship or in the faith-based community or any place else that do not identify. You have people on the down low. And in the Black community, this is just my experience, if you're only talking LGBT or, sex workers or barbershops, beauty salons, service industry workers, hotels, and all of those things, we're sitting here saying, they don't mean us. We don't have to worry about that. And no matter how many times you yell, anybody can get MPOX, but you're not talking about us. So I am saying this to Riverside County, and I'm saying this to the state folks that are working on MPOX, that the whole approach has to be different. So when you talk about, how are we pivoting? I hope and pray that the lessons we learned and all the wonderful things we did in COVID get transferred to MPOX or anything in the future, because right now, I don't see it happening. It's, if you all are working on COVID, somebody else is working on MPOX, and they're not even coming and asking you your lessons learned. Just my thoughts.
Thank you for sharing your thoughts, Minister Deborah. I know that we've had conversations with our Leadership Council about the challenges around the MPOX response, and we know that there are definitely unique messaging and communications frames that need to take it that need to happen in different jurisdictions based on what you're saying, I think, and also with different communities that we're targeting and working with as well. So there's a lot that needs to be taken into account. And I think, yes, loud and clear, we must also apply the lessons learned from COVID in our MPOX response. And I think there are some barriers to that, but I think that I think there's ways to do that. And I think we need to understand how we can do that as well. Salome, I saw your hand up. I wanted to make sure you had a question or a comment you wanted to add.
Yeah, I
let-
wanted to say
please,
thank you to
Don't let
Pastor.
her talk. Don't let her talk. No.
I was gonna say, I don't know what's proper etiquette when it comes to someone that's talking about your agency and what a great job you're doing. So thank you, Minister Williams, for sharing that. I just wanted to address the question that was brought up a little earlier about kind of social determinants of health and beyond. Deborah knows way too well. We have now roped her, the African American task force, and everyone else involved into many other pieces of what we're doing countywide, whether that's coming up with our mission vision statement for the health equity teams or outreach teams, whether that's part of how we will be rewriting our next strategic plan for the department, whether that's how we're gonna have equity kind of lens and focus countywide as opposed to just for the Department of Public Health. So she's now roped into a lot of task forces which address that, and she shouldn't have volunteered herself, but now they're all involved and really informing some of the things and policies that will be in place and written. And then the task forces that we've created through, you know, the larger efforts through vaccine efforts that have now been kind of broken down as we came out of complete DOC COVID response. You know, our COVID vaccine equity task force now turned into an equity and justice task force, where we're kind of beyond that step of just talking about COVID and COVID data, but how that impacted overall community. And so where do we go from there? What social determinants of health are we addressing with the aftermath, the resilience, the recovery phase? And then that same thing goes with, you know, continuing to establish funding sources and streams to move that beyond that. So shying away from COVID work, but keeping that as the forefront of what built this partnership, and then roping them all into different programs, projects, activities, input. Like Deborah mentioned, the Arc of Safety Summit, great partnership in supporting one another, ideas, and just how to keep everyone that was initially brought together still involved and have their input be heard. That's all. See, it wasn't so bad, Deborah.
I keep asking her, what am I doing? What meeting is this? So I think what you're saying is important, Salome. And I'm now on the, I don't know if, I guess it's a task force for creating a strategy around the declaration that the Board of Supervisors made that racism is a public health crisis. And, you know, just getting the input from the community, it's important.
Thank you. I had a follow-up question to some things that you were talking about, Minister Deborah, and I think Salome's alluded to it as well. I think I can definitely see that you all have a good working relationship with each other. And I think that's so important. And what you were really elevating that really resonated with me earlier, Minister Deborah, was about how small groups can be really powerful. And that we need to make sure that we are outreaching to them, make sure that they're supported to participate. And you talked about how Riverside really advocated for your organization, your voice to be at the table. So I'm wondering if you could speak a little bit more, if you have anything else to add about how public health departments or agencies can really support the participation of smaller groups that may not be the traditional institutions or organizations that are usually like at the forefront of, you know, the communications and the news or headlines of doing this work.
Yeah, thank you. I work with a lot of really large organizations, especially in disaster response. And I will tell you that bigger is not always better. And we were so small when we started working, well, before we started working with Riverside County Public Health, that in 2018, it was me and a few volunteers. None of us were getting paid. But we had been activated by the FBI to help with the terrorist attack in San Bernardino. So money is not always an indicator of what you can do. And we did the Listos project after that, and we're able to hire 3 of us. That's it. And then COVID hit. And so even now, when we're fully staffed, there's like 10 of us. That's it. Right? But use us as a force multiplier. One of the good things and one of the bad things, I would say, especially about BIPOC nonprofits, is we've never had any money anyway, but we've always found ways to get things done. That's the good part, but the bad part is it shouldn't be that way. And so one of the things that I would advocate for small nonprofits is give them the funding that they really need. And I would encourage you where you can, and Salome and I kind of have this conversation sometimes, but the restricted funding is really restrictive. Something as simple as we have cases and cases of PPE for adults, masks, hand sanitizers, things like that. But once the children 5 and up or 0 and up started getting vaccinated, we could give masks and hand sanitizer to adults, but the funding is restricted. We can't buy PPE. So we're having to take funding out of our unrestricted funds, which are limiting because we're very small, to buy children's masks. It's things like, things like that. Take the reins off of the funding. Allow us to really operate. Fortunately, we have VA 58. We can't, with certain fund, we can't buy any kind of food. We can't buy snacks. No, that's not a reason that people should come to get a shot. But if we can give them a taco or a hamburger, when they're there, that's more incentive. And so it's those kinds of things that will help small nonprofits. Advocate for your small nonprofits. We may be small, but we are mighty. So that's my thoughts. Get the funding to them that is needed. Don't expect them to do everything for free. Don't expect that. That is one of those under the surface barriers. And here in the inland region, we get a lot less funding overall than Orange County, LA, and probably others, San Diego, probably others. Capacity building. With the African American Equity Collaborative, Salome and we're talking about how can we, building resilient communities as the lead, help with some of the capacity building. Some of them, they've never had to put together a major budget like that. They've never, the procurement process. Free up the procurement process. Don't make it so onerous. So Salome, I don't know if you want to kind of maybe talk about how you all approached it initially by using Reach Out.
Sure. So initially, to get as many dollars out as possible through COVID response, and obviously knowing that we wanted to give majority of our funds to our CBOs to do a lot of the work that Deborah mentioned. And of course, she's a smaller piece of the huge, larger puzzle of, providing funding to the Latinx population, providing some resources and funding to the Native American community, the NHPI community, and so on and so forth. We like Pastor Deborah mentioned, we worked with a lot of other religious entities, namely the Roman Catholic Diocese, just a plethora of partners that we thought we would provide a lot of funding to, that they would be our voices in the community to get, basically we would show up with shots in arms, right? A lot of the work would then be logistically on our side, but our partners would then have a lot of the bandwidth to do outreach, education, translation, canvassing, bringing people, bringing ideas, etc. So we opted to go through a fiscal intermediary that was a larger entity who could support the infrastructure that Deborah was mentioning, of being able to disseminate some of the funds, get it out to the community perhaps quicker than we would through our county procurement contracting processes, even with a declared emergency. And knowing that we would have those barriers in activating our partners, we opted to go with two major fiscal intermediaries, one in the East and one in the West, so that they would push out a lot of the funds. Our contract would be with the FI, that has the bandwidth to provide those reports and regular updates and, fiscal, fiduciary, etc. And then the smaller entities that may not be able to burden those loads would then have subcontracts with the FIs and be able to get their money quickly, and perhaps even upfront in some instances. And we kept that going. It worked out well in a sense of everybody, of course, has some learning to do, because you have a wide variety of partners with different needs and demands in the community. But ultimately a space where it provided a little bit of unity, that everyone's out for the same mission and the same cause. And the county wasn't just using the fiscal intermediaries and saying, okay, well, you guys take it and we'll back off. Like Deborah mentioned, we were very hands-on, but knew our barriers and challenges in getting the funds out there as quick as possible in the hands and in the pockets of those who needed it to do a lot of the work.
Yeah, the other thing I would add is grant reporting. We now have to literally hire somebody just to handle all the grant reporting, because it's different for every grant and different intervals. And so anything that you could do to help with that for your small nonprofits, please do so. The fiscal intermediary that we worked with, they actually are fantastic, when it comes to that. And we've learned a lot from having to submit our monthly reports to them. But small nonprofits, probably even larger nonprofits, I know I now look at, if somebody wants to work with us and they want to give us funding, my question is not how much money is the grant. My question is, what's the reporting? Because if you're offering a $5,000 grant, but you want us to do reporting every week, not that $5,000 isn't important, because it is. And my grant writer already says, well, if you get 10 of those, so, but it's just difficult.
Thank you so much, Mr. Deborah. We really appreciate it. And I think ending on that note of really thinking about where are the things that may get overlooked, but that are such barriers to doing the incredible work and building these partnerships across small CBOs and larger ones and agencies. And so I really appreciate you elevating those finer points that contribute to either the success or challenge a lot of these partnerships. And I do think we're going to wrap up to lead folks into a break, but just want to express our gratitude both for your time today and your insight, and also for the broader work that you're doing in the Inland Empire, and for being such a wonderful partner and collaborator. And if folks have other questions that weren't answered, please feel free to drop them in the chat and we can follow up. And as always, it's wonderful to hear from you and see you, and we really appreciate your time.